All right, so it's my pleasure to introduce Dr. Lynn Trotti. She's an Associate Professor of Neurology at Emory University, where she also completed her neurology residency, her sleep medicine fellowship, and Masters in Clinical Research. Clinically, her practice is focused on the treatment of people with hypersomnolence disorders. Her research work focuses on the pathophysiology and treatment of the central disorders of hypersomnolence, primarily through clinical trials and imaging studies, as well as on REM, sleep behavior disorder, and restless leg syndrome. She is a member of the Hypersomnia Foundation's Medical Advisory Board and the American Academy of Sleep Medicine's Board of Directors. Thank you, Dr. Trotti.
Thank you. Good morning, everybody. I'm always excited to speak at Beyond Sleepy, but I'm especially excited this year to be presenting some data from the Hypersomnia Foundation's very own research registry. I don't have any financial disclosures to make. You did hear I'm on the board of the AASM. I'm also pretty opinionated. Please know that any opinions I express are just my own statements. They have nothing to do with statements of the AASM. So we're going to go back in time. 10 Beyond Sleepy conferences ago, I gave this talk on information being power and contributing to the registry for central disorders of hypersomnolence at CORDS. 10 meetings ago. And the field was in a really different place back then. The foundation was like really small and new then compared to how it is now. It's hard to imagine a little bit from how much growth there has been since then. But really at that moment in time, the question was, with the resources that HF had, what was sort of the best way to try to move the field forward quickly? And lots of organizations were really focusing, and still are really focusing, efforts on the idea of patient registries. If you can take information, if you can gather information from as many people as possible, not just in one clinic, not just in one city, but as broadly as possible, you can learn about the disease from that quantity of information in a way that you never could at a single site or a single research group. This was the CEO of Genzyme at the time saying, for a rare disease community in particular, because an individual site is only going to have a few people, creating a registry of patients is the single most valuable action that a rare disease community can take to make the disease easier to study and increase the likelihood of there being treatments developed. So I gave this talk and I said, hey, this is why we need a registry. One, you heard great data from Dr. Maskey talking about clinical trials, and clinical trials are absolutely critical to move the science forward, but they answer the question of how does a drug work in a very, very carefully selected population, in a very, very tightly controlled, not really real world environment. A registry can answer the question of, in real life, as people are going to see doctors all across the country or all across the world and are taking medicines and living their regular lives and not having special visits just because they're in the study, what happens? Do the drugs work or not? Registries can also be used to look at trends in healthcare. They can be used to understand really the impact in the real world of the symptoms. And sometimes registries also have the option to let people sign up to be contacted for future studies. Even if they don't, there is power in having a registry to say to people who might want to do research, like drug companies, hey, we have a registry of X number of people with IH or with narcolepsy type 2 or Klein-Levin who are invested. They are donating their information to this registry. This is a real pool of volunteers to be tapped if you wanted to do future studies. So particularly for rare diseases, registries have lots of value. So I gave that talk. I don't think my talk had anything to do with it, but there was an incredible, incredible, incredible response to the launch of the Hypersomnia Foundation registry. So what you're looking at is basically in the first year of the registry, over 500 people signed up. This is extraordinary. when we were talking about like, well, how many people might sign up for the registry? I promise you the number was not that high. It was really an incredible response. And then the year after that, another 500 plus people signed up for the registry. And so it was really, it was really incredible that that many people were willing to share their information and be part of the science. But also, I think it really spoke to the fact that like, this is a community whose voices had not been heard and the importance of that voice. So a few years ago, we went and we looked at just the first time people entered their data into the registry. What did the data look like? And we published this paper. So I've talked about this at prior meetings of Beyond Sleepy, but I'm just going to kind of give a little high level of just at the first point in time when people were in the registry, what did it look like? And so for that first paper, we looked at 563 people, of whom almost all had IH. The registry is open to people with any central disorder of hypersomnolence, but it tends to capture mostly people who have IH. And so it's about 468 people with IH, about half and half people who were long sleepers and people who had normal sleep durations by their self-report. And then about 10% of people with narcolepsy type 2, 10% of narcolepsy type 1. You'll note that 563 is less than 1,000 people who entered for a variety of reasons. We had to make some choices in who to include to try to be as sure as we could that people had the correct diagnosis of IH. And in particular, one decision we made back then that we've stuck through in our analyses of the registries, but is that for people who said they had two things, they had IH and narcolepsy, we decided to put them aside. I understand why people end up in that situation where they've been given two diagnoses, but to really look at diagnoses, we put some of those people aside. So still more than 500 people in this initial study. They were mostly women, partly because people with IH probably are a little bit more likely to be women, but also women are a lot more likely to do a study like this. And I don't make the rules. It was mostly US based, although the registry is open to the whole world as long as you are English speaking to be able to enter data. Average age of onset of sleepiness symptoms was 19. About 7 years later was the average age that people went and first sought medical evaluation. Often people sort of don't realize it's a medical problem right away because there's so many other things in life that you could sort of accidentally blame, not realizing it's a medical disorder. But by the time people were taking the survey, the average age was 36. And we asked people, when your symptoms were at your worst, how bad was this or how often did you have this problem, at least daily? And then now on your current treatment, do you have this symptom at least daily or not? And so that's what you're looking at in the figure. The dark blue is on treatment, and the light blue is when symptoms were at their worst. So when symptoms were at their worst, everybody was sleepy, of course. Sleepiness defines these disorders. But most people also had difficulty with waking up. Most people had brain fog. Most people had memory problems. The dark blue shows that treatment helped some. Those are still pretty big numbers in the dark blue bars. So despite being on treatment, 50 to 60% of people were still having these symptoms daily. We wanted to look across diagnoses. Remember, the narcolepsy type 1 and the narcolepsy type 2 groups in this registry were very small, about 10% each. Mostly it was IH, but we wanted to see if anything really jumped out across diagnoses. And for intentional naps and unintentional naps, people with IH took less than people with narcolepsy, but brain fog was quite similar across diagnoses. Long sleep, we were surprised to see quite so many people with narcolepsy type 1 reporting long sleep, because that is not sort of what we see in our textbooks. But that is certainly what we saw in the registry. So that was one moment in time, the first time people did their questionnaire. We really want to understand what happens to IH over time. We want to understand that about narcolepsy type 2 and narcolepsy type 1 and Klein-Levin also, of course. But we decided because the registry was so heavily enriched for people with IH that for these longitudinal analyses that I'm going to tell you about, we would just focus on the IH group. So what do we already know about what happens to IH over time? Well, not so much. You'll hear a little bit about this study later on today or tomorrow, I can't remember which, from Dr. Plant, who did this study. There is a long-term sleep study out of the state of Wisconsin called the Wisconsin Sleep Cohort. And it's a sampling of state employees of Wisconsin, originally to look at sleep apnea, so enriched for people who have snoring. But they have been sampling people in this cohort and testing their sleep for years and years and years at a time. And so it's this incredibly rich resource to look at what happens to sleep in general over time. But it wasn't designed to do anything about IH. Dr. Plant, though, is resourceful and motivated to learn about IH. And so he went back to the data and he said, well, we did MSLTs and we did Epworths and we asked people about their sleep and shift work and all the things we would have to rule out. So we can go into that database and figure out who had IH and then see what happened over time. And that's what he did. So the figure that you're looking at is my take-home point from this slide. Each line is a different person in the Wisconsin sleep cohort who is presumed to have IH based on their data. And what you can see is you can't see a pattern. Some people's sleepiness got worse. Some people's sleepiness got better. A lot of people were up and down over a period of up to 20 years of follow-up. And so this is only a handful of people because there weren't that many people with IH in the Wisconsin sleep cohort. But you certainly get a sense that at least if you go out in the population, there's not a clear trend of getting worse or getting better in that small sample, large sample, small sample with IH. Well, what if those people didn't really have IH, you say, because they didn't see a sleep doctor to get diagnosed with IH? What do we know about IH over time in a sleep clinic where we're like as sure as we can be that people have IH because they're seeing an IH specialist face-to-face in clinic? And so that's what you're looking at here. This is from a sleep clinic where they wanted to look what happened to their patients with IH over time. And so they took 60 people whose IH had been diagnosed at least 3 years ago, although for most people it had been like 10 years ago. And then they looked to see what happened. For most people, 83% of people still had symptoms of IH at the end of their follow-up, but they didn't necessarily still have diagnoses of IH. So a group of people developed new diagnoses that then they said, oh, well, maybe this was what was happening all along, either a severe mood disorder or a severe medical disorder. Some people developed a severe sleep disorder. And so they sort of no longer really qualified for an IH diagnosis, even though they still had the symptoms of IH. So that's interesting. That's good to know. But that's 60 people. And it's at one site, and there might be something that's sort of different about IH from place to place in terms of how we diagnose it, right? We have the rules, but we all interpret the rules, and so on. And so that's really what we wanted to look at in the registry. Because we have registry participants from all over the US, from some countries outside of the US, that's lots and lots of different sleep clinics that are represented. But we know that people were diagnosed with IH by a medical professional because you have to do that to get into the registry. And so it's sort of, it has aspects of the two kinds of studies I showed you, but some different benefits as well. Usually people put their thank yous at the end of their talks. I'm putting my thank you right here in the middle before I go into these data. This is Adrika Chattaraj. She is a total rock star. She just graduated and is an Emory undergraduate this May. But basically, she approached me a couple of years ago and said, I'm really interested in the science behind sleepiness. I'm really interested in some of the work you're doing. Can I please do some research with you? And I said, sure. And she was interested in flies. And so I got her involved in some fly research that we're doing on sleepiness. And then she said, you know, flies are great, but I really like people. So, can I please do some people research? So I said, sure. And so then we requested data from Cords to look at this follow-up project. And so even though I'm the one up here on the stage telling you about this work, none of this would have happened if Adrika had not like made it happen and done the hard work here. So, oh, yeah. Okay, so what happened over time to people in the registry? So there were 468 people with IH that we used in the first paper that we published on the registry that I just told you about. And so we decided to use the same sort of inclusion criteria to define people who had IH. And 323, so 69%, did the questionnaire at least 2 times who had IH. So this work is all looking at those 323 people who did the questionnaire at least twice. And they did it at least twice between June of 2016 and June of 2023 when we had to request the data. Just to make sure we weren't capturing people who like started the questionnaire one day and it was a long questionnaire, so they had to take a break and they went back and like did the rest of it the next week, we made sure that the 2 questionnaires were at least 6 months apart in time. And at both time points, we asked people to sort of confirm to us that they had an IH diagnosis in a variety of ways. And so they had to meet those criteria both times they filled it out. So somebody who had IH the first time, but then later developed a diagnosis of narcolepsy type 2 or something else wouldn't have been included. IH at both time points. And we asked people about their symptoms either sort of in the current times or in the last 30 days. Shout out to the person in the registry who completed the survey 9 times in that time period. That is amazing. For statistical reasons, we took the first time people filled it out and the last time people filled it out. I have to go back and figure out how to use those 7 ones in the middle. But again, mostly women, the mean age 35 at the first response. The average time between the first time that people filled it out and the last time people filled it out was 2.4 years, as short as 6 months and as long as 6.8 years. But about 2.5 years time frame is what we're looking at when we look at how things have changed. So what do we want to know happened, over time? So we wanted to know what happened to symptoms. And particularly the symptoms we looked at were sleep durations for weekdays, weekends, naps, and then sort of who was a long sleeper and who was not a long sleeper. Of course, we wanted to look at excessive sleepiness generally, but also naps, both intentional and unintentional. Sleep inertia, this great difficulty waking up in the morning, is a huge problem for lots of people with IH. We asked about it in multiple different ways because no one sort of established the best way to ask that question to try to get at what we're looking at. And so we asked people, do you need multiple alarms? Do you have trouble waking up with normal levels of alertness? Do you have difficulty waking up during the day? And similarly, as you kind of heard Dr. Maskey say a minute ago, we're not totally sure how to capture brain fog and the cognitive symptoms that go along with IH. We don't really know how to pick those up on questionnaire precisely yet either. So we asked about brain fog by name because lots of people use that term. And then we asked about memory problems as well. We were also really interested in what happened to medication use over time in the real world, not in a tightly controlled clinical trial, what's happening with these medications. We wanted to know about other comorbidities and other diagnoses. There's lots in the registry that we did not look at for this study. There are a ton of questions. There's a ton of data in there. So lots more still to learn, but those are what we're looking at: symptoms, medications, and comorbidities. Symptoms really didn't change much. So a little surprised that this was not different than it was, but science. What you're looking at is the bottom sort of medium blue bar are people who had the symptom every day the first time they did the questionnaire, and they had it every day the second time they did the questionnaire. The green on top is people who didn't have it every day the first time and didn't have it every day at the last time. The 2 bars in the middle that are really small are people who it went away or it started. And so basically what you see, although the amount of people struggling with it depended on the symptom, those middle bars are always really small. Not that many people got better, not that many people got worse. They mostly stayed how they were the first time they filled out the questionnaire. And we did that for sleepiness, long sleep, trouble waking up in the morning, and brain fog. We also didn't see changes really over time in memory problems. We didn't see changes over time in needing multiple alarms. And when we looked at sleep durations, nighttime sleep on work days, nighttime sleep on non-work days, and nap durations, the averages were within 10 minutes at both time points for all of them. About 8.5 hours on work days, about 10.5 hours on non-work days, about 2 hours for naps. There were small improvements in difficulty awakening. So one of our 3 ways of asking about sleep inertia, like 79% of people had it the first time and 73% of people had it the second time, which was statistically significant. I'm not sure how clinically meaningful it was, especially since our other numbers didn't change. So basically, in 2.5 years, symptoms don't change much. We have treatments for IH. You just heard about them from Dr. Maskey. I tend to put medications into 4 buckets when I think about IH. There's the one that's FDA approved you heard about, which is lower sodium oxybate. There are things that the AASM guideline that she showed you recommend. And then there are things that are FDA approved for narcolepsy that we kind of borrow for IH and just sort of assume that they work for narcolepsy type 2, they're going to work for IH. And then there's a handful of sort of miscellaneous medicines that we think might be useful. We are not great at targeting treatments to symptoms of IH yet. Most of the clinical trials really focus on sleepiness as the outcome of interest. We're getting better as we use things like the IHSS scale that you heard about that looks not just at sleepiness, but at other symptoms of IH. But it means a lot of times we don't have a lot of data for which symptoms get targeted by which medications. And so sleepiness, we sort of understand what the medicines do. For disease severity or quality of life, we have a sense. Little data on sleep inertia, but some of these really important things like cognition, brain fog, fatigue, and daily functioning, we don't have a lot of data on. And I think part of what we may be seeing in the registry in terms of medications is the things that clinical trials aren't measuring. The clinical trials are going to give you an Epworth scale, and it's like the Epworth will go up or the Epworth will go down or the Epworth will be unchanged. But like living with a disease is more what factors into whether medications work or not in the real world. So what had the registry participants taken ever for IH? So this is in terms of what had been taken by the most number of people to the least number of people. 242 of the 300 some people had ever taken modafinil. Over 200 had ever taken methylphenidate. Amphetamine, dextroamphetamine, brand name of Adderall, had been taken by almost 200 people that had armodafinil. And then the numbers go way down. So a couple of other stimulants we looked at, lisdexamphetamine, which is known as Vyvanse, dextroamphetamine, which is half of Adderall, clarithromycin, any oxybate. For this study, because it launched before lower sodium oxybate was invented, lower sodium oxybate was not a choice, but people could write in what they were taking. And so we took out, whenever anyone wrote in that, we counted that and we sort of lumped all of the oxybate preparations together because some people also wrote in once nightly sodium oxybate. And then flumazenil, solriamfetol, and pitolisant. You can see all those were barely ever taken by anyone in the registry. Solriamfetol and pitolisant also didn't exist when the registry was launched. And so again, those were people who had typed in that they had taken them. So remember that I just told you persistent symptoms were really common over the 2.5 years. So at the last time that people filled out the survey, most people, over half of people were still sleepy every day. Over half of people still had severe sleep inertia every day. Almost half of people still had cognitive symptoms every day. And remember, those symptoms didn't change much over time. So you might think if people were still really, really symptomatic, there would be a lot of medication changes happening to try to fix that. That is not what we saw. What we saw was that actually, most people were medicated. Not even everybody with IH was on medication. So 86% at baseline and 85% at follow-up were on anything for their IH, which of course means that 15% of people were completely untreated for their IH. at least with the medication. We define medication changes here as either starting a new medicine between the 2 time points, restarting a medicine between the 2 time points, stopping a medicine between the 2 points, or both starting and then stopping again between the 2 time points. We didn't have a way to measure if changes in dose happened. And we had to group some medications together. All the oxybates were grouped together. And with methylphenidate, I also grouped dexmethylphenidate and serdexmethylphenidate because there were just a tiny handful of people who had taken the other 2. So in the 2.5 years, when over half of people still had persistent symptoms, the average number of medication changes was less than 1, 0.8. What you are seeing in the figure is how often people had different medication changes. And so that big blue that's over half is 0 medication changes in the 2.5 years. And then you can see sort of going around the circle, 1, 2, 3, or 4 medication changes during the study period. When we looked at trends over time in medications, meaning were any medicines more likely to be stopped or started over the study period, the only one that showed a significant change was modafinil because it was stopped by 11%, but only started by 4%. So that turned out to be, again, statistically significant, a little bit of a difference in the use of modafinil over time. This, I think, is really depressing, which is that less than half the people who ever tried a medication, not just in the study period, were still taking it on their final time point. So amphetamine, dextroamphetamine was the best. This was only medications that at least 50 people had tried. This is pretty consistent with what we see in smaller clinical series, but this is stronger data because it's more people. It's actually not that different from what we see in the lower sodium oxybate long-term follow-up study. So this is the follow-up of the clinical trial Dr. Maskey described. Of the 154 people with IH who ever took the first dose of the study drug, they followed people approximately 40 weeks, and just shy of 2/3 of them were still taking it. So there does tend to be a dropout over time. Anxiety and depression were both really common in terms of comorbidities. Anxiety became a little bit more common over time, but depression was pretty stable. We didn't see a lot of the comorbidities that we know are out there in people who have IH. A few new diagnoses of things like dysautonomia, fibromyalgia, and ADHD over time. So finally, my take-home message: symptoms are pretty stable over 2.5 years. This is depressing, and we would like to see them getting better. On the plus side, they didn't get worse and worse and worse. And so that's good. The medicines that we have are clearly not good enough. Most people stop them. Many people still have symptoms despite them. They're helpful. They're better than nothing, but better than nothing is a really low bar. But also, we're not making good enough use of the medications that we already have. Most people didn't change medications. Many people have never tried pretty standard of care medications for IH. But really, my biggest take-home message is none of this could have happened without participants in the registry. Not everybody wants to be involved in research, and that is totally fine. But everyone who does anything to help research forward really helps us learn things that we couldn't know any other way. And none of this would have been possible without people being in the registry. Good news, it's not a past tense kind of situation. There's lots of ways to get involved still. If you're already in the registry, you can keep updating. Try to beat that person who's done it 7 times. You will hear a lot about the DREAMS portal through the Sleep Consortium. This is getting at some of the same data in a really different way. And so I think it's going to be a beautiful complement to what has been done with the Foundation Registry. And then, of course, there's clinical trials and lots of other options that you can find more about at the Foundation website. Thank you so much.
Thank you, Dr. Trotti. That was a great presentation. We have time for a few questions. So if you have a question for Dr. Trotti, raise your hand nice and high. We have some volunteers here.
Hi. Yes, hi. What are the risks of putting yourself on the registry, and who is that information available to?
Yeah, that's a great question. And it depends entirely on what the registry is. And so, like with any research, it's really, I think, the most important question when you're trying to figure out if you want to participate in it or not, or what are the risks, and are those risks I'm comfortable with or not. And so different registries will have different ways of protecting data. They'll have different, so for the Hypersomnia Foundation registry, I could request data from CORDS, which is the keeper of the data. I didn't have anybody's name. I didn't have anybody's date of birth. I didn't have any way of identifying anybody who was in there. And so I got a ton of information about people, but none of it was identifiable. I couldn't link it even to my own patients. I have no idea if they were in there or not. And I would say that's pretty standard for registries like this. They're going to collect the minimum amount of data that they need, and they're going to release it to the absolute smallest number of people. Any science that can be done without it is done without it. But every registry is going to deal with that a little bit differently. So that is fine print that's worth reading.
We have a question from one of our online attendees. Has there been any evidence that environmental factors like heavy metals or mold or plastics, et cetera, could play a larger part in the diagnostic journey?
That is a great question. No, we are still pretty wide open in what we think IH might be. There do seem to be people who have had symptoms for sort of as long as they can remember. People will come in with their parents, and their parents will describe them like sleeping in unusual places when they were toddlers. But then there's a group of people who have symptom onset later, right? They probably were okay as kids. They probably didn't have pathologic sleepiness in their early teen years, and it really developed later on. That second group is probably going to be higher yield to look for something environmental than that first group. But we really don't have any data on the question yet.
Hi. When you're looking at the number of times people had changed medications over the course of the surveys, did you ask participants how many medications they had tried prior to their first survey fill? Because I think for a number of people, they might try a number of medications fairly rapidly, as rapidly as possible, fail at a lot of them, and maybe find one that helps a little, and then stick with it even though it doesn't help much.
Yeah, we did. We basically, for every medication, we asked, have you ever tried this? Are you still taking it, et cetera. And so one of the slides was really how many people had ever taken it. So like modafinil had ever been taken by, 200 and some of the 300 and some people. None of the other medicines have been taken by more than about 200 of the 300 and some people, and that's ever having taken it. So I think you're right. There are some people in the registry who had had their disease a long time. They'd sort of already tried everything, and they stuck with the best thing. But if you look at the numbers of how many people have tried a particular medication, there's lots of people who haven't tried a particular medication. And there's reasons for that too, right? If you've tried 3 amphetamines, do you really need to try the 4th amphetamine? Probably not. But I was a little surprised looking at the data at how low some of the numbers were for things that people had tried.
Rebecca?
Hi, you mentioned that a lot of people discontinued their medications, like that was like more common than staying on something in the long term. I'm wondering if you're aware of any research on why people might have stopped, if it has to do with access, like insurance issues, or if it's a choice.
Yeah, we in the registry, there's not a question about why people stopped a medication, but there have been some other patient surveys that have looked at that, and it's exactly as you say. It's lots of reasons, right? So if insurance doesn't pay for it, some of these medicines are ridiculously expensive, and so that's a reason. Side effects are clearly a reason. The medicine just not working is clearly a reason. So yes, I don't think there's one reason why people are stopping it, and certainly I don't think the medicine's not working well enough is the only reason that people are stopping it. But that's got to be part of the equation, just looking at residual symptoms.
Thank you.
Thank you. We have time for a couple more questions. So if you have one for Dr. Trotti, raise your hand nice and high. And in the meanwhile, Dr. Trotti, somebody online is asking about Lumryz just being granted orphan drug status, and they're wondering if you could explain exactly what orphan drug designation means.
Yeah, so and I'm not an expert in patent law, clearly. When the FDA grants approval for a medication, with that comes certain protections for the medication. So when you have a new medicine, it's only available as a brand name medication, that's because only the company is allowed to make it. No one else is allowed to make that medication for a period of time. And then when that window ends, then anybody who wants to can go make a generic version, and not anybody who wants to, but anybody who wants to, who's approved to, can make a generic form. And so then there's price competition, and so then the price tends to go down. And there's lots of different generic manufacturers available if it's a medicine that enough people want to make. This protects the drug companies. The drug companies spend a lot of money developing the drug, and so they have a period of time where they're the only ones who can sell it, and so they can make back their costs for having developed the drug in the first place. For orphan drugs, meaning for drugs that don't have a big population of people who are going to need them, they're only going to apply for a small population. That normal window of time of drug exclusivity, where you're the only company who can sell it because it's protected, may not be long enough to make up the costs of the medication. And so orphan drug gives the company a longer window of time where they exclusively can make and sell the drug. And so it gives them more protection over time to help them come up with some of their costs. And so it's usually given for drugs that, one, are targeting a relatively small population, and two, are filling an important clinical need that there aren't a lot of other available medications to fill.
Thank you, Dr. Trotti. Rebecca, did you have somebody? Okay.
There seem to be some people whose symptoms go into remission over time. I was wondering if there have been any analyses that have looked at those individuals and perhaps tried to draw correlations as to why.
Yeah, I think it's a really fascinating finding. It's been shown in a variety of sources. And so there have been probably 5 or so clinical series now where people look at their clinical populations and say, oh, this percentage of people, their IH seem to go away. That's mostly where we've seen it. I thought we might see a little bit more of it in the registry. It might still be in there, but since we sort of said you have to have IH at both time points, the people who truly went away, 1, wouldn't have been captured, and 2, probably wouldn't have filled the questionnaire out again. So I'm not sure the registry is the best place to answer that either. Really what you would want is to get those people back and do some pretty careful comparison testing of them to people with continued IH. But really what you'd want is to have all of those people 10 years earlier, right? To really do a lot of careful phenotyping of people at baseline, and then over time you can follow them and see what's different. Those are really hard to do in a clinical population, especially because the people who get better tend to stop coming back to tell you that they've gotten better. But I think the fundamental question there of what's different about those people is absolutely critical. If we could understand why some people it was going away, it might give us a lot of insight into what's causing the disease in the first place.
Thank you so much, Dr. Trotti. Unfortunately, we are out of time, everyone, but Dr. Trotti is going to be back later for a panel discussion. So round of applause for Dr. Trotti, please.